Hello, my name is Caitlin Herr, and I will be presenting on the mental health challenges among military service members. So for my introduction, military service presents a unique psychological environment. Service members deal with chronic stress exposure, high operational demands, and a culture that prioritizes resilience and mission readiness and war fighting capabilities. So this contributes to a range of mental health challenges that adversely affect military personnel compared to the civilian populations. So understanding the psychological mechanisms underlying these outcomes require a more in-depth analysis of both individual and systemic factors, which include things like combat exposure, stigma, leadership influences, transitional stress, and support systems. So in doing my literature review, I've found a couple things. So research has shown that exposure to combat is strongly associated with increased rules of PTSD, depression, and suicidal behavior. There's a stigma around mental health in the military, which discourages people to seek help, and it reduces engagement in treatment as well. Also, something else that was found was that leadership is a critical factor in shaping mental health outcomes. So having a supportive leadership can reduce the stigma and even encourage service members to utilize the mental health resources provided. Also, during transitional periods like post-deployment or separating from the military, that has been linked to increased psychological distress and elevated suicide risks. And this is due to identity disruption, a loss of structure, and reduced social support. These negative effects of trauma can be mitigated by having protective factors in place, such as resilience and having a strong social support system. But even despite that, there are structural barriers, such as concerns about confidentiality and access to care, which continue to limit the effective treatment use among service members. I use scholarly, peer-reviewed articles and authoritative sources to analyze and identify key themes related to combat exposure, stigma, leadership influence, transitional stress, and social support. This review provided a comprehensive understanding of the factors contributing to psychological distress and suicide risk within the military population. And rather than collecting data, I just integrated existing research to evaluate patterns, relationships, and gaps in literature, which allow for a more multidimensional analysis of both individual and systemic influences on mental health outcomes. Combat exposure as a primary risk factor. So it's no secret that combat environments expose service members to things like threat, injury, death, and moral conflicts. Experiencing higher combat environments is associated with greater PTSD and depressive symptoms. In conducting my research, it's been found that repeated traumatic stress is linked to overwhelmed coping systems and impaired emotional regulation. Combat exposure and suicide risk. So obviously, higher combat exposure has been found to also be associated with increased suicide attempts. Joiner's interpersonal theory of suicide is actually used to explain this pattern. Military experience may raise acquired capability for self-harm, while transition and isolation increase burdensomeness and that thwarted belongingness. PTSD and comorbid conditions. So according to the DSM-5, PTSD symptom domains include intrusion, avoidance, negative cognition, and hyperarousal. PTSD in the military population often co-occurs with depression and substance abuse disorders. So comorbidity actually complicates treatment and can increase functional impairment and suicide risk. Stigma and the military culture. So it's the military norm to prioritize being tough, having discipline, self-reliance, and being mission ready. People get concerned about being weak, peer judgment, confidentiality, and damage to their career when it comes to seeking help. So this stigma really reduces treatment initiation and retention. Leadership climate matters. Leaders in the military really can shape whether mental health concerns are normalized or suppressed. Having supportive leaders can help reduce the stigma, whereas dismissive leadership may reinforce silence and even delay treatment. Reintegration after deployment. Returning from a deployment requires psychological adjustment. The service member is going from high intensity operations to routine life again. Veterans may experience identity disruption, social isolation, and even relationship strain. Delayed adjustment problems can actually intensify these existing mental health symptoms. Separation from the military involves a loss of identity, structure, role clarity, and social support. It's actually been found that the first year after separation is especially high risk for suicide. So the service member is dealing with employment, healthcare, and cultural changes, which add on stress because that's a lot to deal with all at once. Family systems and social relationships. Not only do deployments affect the service member, but they also affect spouses, children, and even parents. The parents of the service member. Family strain, role renegotiation, and prolonged stress can worsen the psychological burden that the service member is already dealing with. So having a strong support system is a major protective factor to have. Relocation and disrupted support networks. So service members go through frequent permanent change of station or PCSs. These moves disrupt social networks and stability. Relocating also affects military partners, which can indirectly affect the service member because obviously the service member cares about their partner or their family and can see that it's adding strain on them, which adds more on top of their plate. So having little to no support really weakens an important buffer against stress. These are some of the protective factors. Having resilience can support adaptation and recovery after adversity. Having a strong family and community improves reintegration outcomes, and also improving or working on adaptive coping and cognitive flexibility can help reduce symptom severity. Not everyone is the same or experiences things the same. For some, mental health symptoms can emerge months after deployment rather than immediately, and that's why it's important to have ongoing monitoring, which is essential because the stress may come up after the structured deployment context ends. Structural barriers to care. These barriers include stigma logistics, confidentiality concerns, and system navigation. Misconceptions about damages to one's career continue despite the evidence that actual consequences will happen. And these barriers prevent military members from seeking help and continuing care. Recommendations for future research. Longitudinal studies on mental health outcomes. Future research should track military members over time to better understand how mental health symptoms develop, persist, or worsen across the military lifestyle and separation. Stigma reduction, intervention. More studies are needed to test specific programs aimed at reducing mental health stigma within the military and evaluating their effectiveness. Technology-based interventions. So there also should be more studies that evaluate the effectiveness of telehealth, mobile apps, and even online platforms in improving access to care for military members. For summary of the research, mental health challenges in the military are quite complex. Combat exposure, culture, stigma, leadership, family strain, and transitions interact to shape these outcomes. A comprehensive, proactive, and supportive system is essential to reduce suffering and suicide risk while sustaining readiness. This is just a list of my references. And then my reference list continued. But that is it for my presentation. Thank you.